Next, we're going to get into our musculoskeletal disorders. So this is going to be our second topic, the final topic for exam 3. So the first specific disorder we're going to talk about is osteoporosis, which is kind of the removal of density of bone tissue. So we can see osteoporosis in these bones. So this would be a kind of mild osteoporosis leading towards very, very severe osteoporosis over here. So again, the osteoporosis, it's a metabolic disease where the body leaches out calcium that it stores in the bones for metabolic use. And this tends to happen with advanced age. And the real problem here is that as this happens, the bones become much more brittle and prone to breaking associated with that decrease in density. The other kind of osteo disease that we want to focus in on is osteoarthritis, also known as degenerative joint disease. So this isn't a deterioration of the bone, but rather a deterioration of the cartilage in between bones at the joints, meaning that the normal space that sits between bones, that's cartilage, which is that smooth articulation surface in the joints, degenerates over time, and we actually see a narrowing. So eventually there's bone on bone movement when patients articulate their joints, which can be quite painful for patients, as you can imagine. So the symptoms we tend to see for osteoporosis, we don't really tend to see a lot of symptoms. So there's not pain associated with that. There's no metabolic abnormalities that we see with patients like this, like diarrhea, anything like that. The things we do see, so as patients age, they start to have recurrent fractures, and fractures that may be disproportionate to the level of injury they may have. So patients who catch themselves on a wall with their arm but end up with a fracture of the arm. So that would be a very severe injury for that mechanism or that amount of force of injury. The other big thing we see with osteoporosis is a change in height. So patients get shorter as they get older because of the compression of the discs in their spine, which is part of that osteoporosis picture. For osteoarthritis, that degenerative joint disease, we see joint pain, especially within an hour in the morning and evening. Usually midday, as patients start moving, the pain kind of goes away, but as they have been immobile and then start to be mobile, that's when they have pain. It doesn't have to be directly over the area of injury either. They may have referred pain. So sometimes patients with degenerative joint disease in their hip, they'll actually feel it kind of in the groin or in the buttock, somewhere around the hip, but not be able to identify it directly as hip pain. Patients who sitting becomes difficult, and the stiffness associated with immobility, especially in the mornings and the evenings, also very common. Deformity of the joint can also occur because this bone-on-bone grinding can result in inflammation. So you can start to see swelling around the joints where advanced osteoarthritis is taking place. The other thing that you can actually assess in these patients is called crepidation or crepitus, which is that grinding feeling that you can have. Like if you put your hand under a patient's elbow who has osteoarthritis, you'll actually feel a grinding or like a clicking when you move their elbow through its normal range of motion. And you can feel it over the hips, the knees, the elbows, shoulders, kind of anywhere. But it is that grinding sensation that's very kind of common with osteoarthritis. So our nursing diagnoses for osteoporosis, risk for falls is a big, big deal. Because of that decreased bone density, patients who fall down are much, much more likely to experience injury as a result of those falls than patients with normal bone density. So we do need to be very, very careful of patients with osteoporosis and their fall risk. Disturbed body image can also become a thing, especially as patients age and they start to get that kind of shorter, kind of different posturing that does tend to be associated with osteoarthritis, or osteoporosis, excuse me. For osteoarthritis, we get things like chronic pain, especially in the mornings, evenings. Those patients will experience pain long term, and impaired physical mobility around that crepitation that they feel in their joints. So they may, because of that clicking, it may be very uncomfortable. They may be less likely to move those joints through their full range of motion. So for the medical plan, we want to try and minimize the risk factors because we don't have cures for either one of these diseases. They are chronic diseases that we don't have a treatment for. So the best we can do is try and minimize the risk factor and slow the progression of the disease, not actually cure it. So smoking and alcohol use are, it's nursing school, so they're obviously bad, but smoking and alcohol use promotes acidosis in the body, meaning that there's a much greater likelihood of the patient having decreased, sorry, my wife is staring at me through the window right here and it's creeping me out. She's being weird. But smoking and alcohol use can lead to an increase in bone loss. So the body's going to pull out some of that calcium in the body, from its stores in the bones in order to fix this acidosis problem. Alcohol is bad, especially excesses of alcohol are also bad because they can decrease bone formation. So the ability to put calcium back into those reservoirs in the bones, which can be a problem. Also, excess caffeine intake can cause calcium loss through urine. Caffeine is a mild diuretic, so it's going to cause elimination of a lot of electrolytes along with water. So we can, with excessive caffeine intake, those like people at the nursing home that all they ever drink, the only liquid they ever drink is coffee, they're at increased risk for losing calcium through their urine. And then medication management, we want to give medications that are going to inhibit the reabsorption of calcium from the bones, meaning we're going to try and limit that leaching of calcium that's stored in the bones that's going to cause osteoporosis. And these are long-term medications that patients get like once a month, something like that. Things like Fosamax, Boniva are some common ones that we do tend to see. For the nursing plan for osteoporosis and osteoarthritis, fall prevention is a big deal, and techniques to do that. So things like getting up slowly, being very, very careful about things like orthostatic hypotension, and also being aware of kind of sharp surfaces on furniture around them so that they don't accidentally bump into those pieces of furniture and cause injury. And we want to teach risk factors. Things like their environment. So if we're working in a home care environment, do they have lots of thick rugs on the ground, cords draped across the ground, those sorts of things. And then things that will accelerate the disease process. So smoking, alcohol, excessive caffeine use, lots of caffeine use can accelerate that leaching of calcium from the bones. Things we want to promote: regular exercise. So impact exercise does stimulate the body to keep calcium in the bones, to keep them stronger structurally. So regular exercise and low impact exercise. It doesn't mean we want to start pounding them on the ground, getting them running marathons, things like that, but low impact exercise to start straining the bones so that they do kind of trigger that the keeping of calcium in the bone structure rather than leaching into the circulatory system can be really beneficial to slowing the progression of osteoporosis. So when we look at risk factors, here's a lot of the risk factors that we're looking for. The primary age group that's going to have the highest risk for osteoporosis is Caucasian women of advanced age. That's the highest prevalence population. So then for implementation and also evaluation, prevention of injury is the name of the game. These patients are at risk for injury associated with the limitations in how their joints move, and also risk for injury associated with their decreased bone density. So if they do fall, have an injury, they're much more likely to require more medical care associated with that injury and much more likely to break a bone associated with that fall. And then symptom control, particularly for our osteoarthritis. When we're talking about pain in the morning and the evenings, we want to make sure that we're getting medication for those patients to minimize that pain, because we always want to treat pain so that patients can be active rather than them self-limiting activity because of fear or pain. Postural changes that we tend to see because of osteoporosis, kyphosis and lordosis are the big ones. And these postures, they're not without their risks. They do tend to lead to increase in crush fractures in the vertebrae, femoral fractures, especially at the femoral head, which is like a hip fracture, and wrist fractures associated with falling. Those are some of the big things we want to look out for with osteoporosis and osteoarthritis.